So not only is Saif an active member of the PROSTAID Calgary Board of Directors, he has an interest in the research field. And along his way, he has obtained 3 accounting designations from 3 countries, and he now manages his own accounting business here in Calgary. Saif recently attended the Prostate Cancer Research Institute conference in Los Angeles, and tonight he's going to share with us only some of his learnings, if you can believe it, because there's a pile of slides in here, so he must have learned a lot. And we're lucky he's going to share that with us tonight. So without any other delays, Saif, come on up.
Good evening, everyone. Brad, thank you for the introduction. I was going to start off with that, so I really don't know where to go. So as Brad mentioned that I'm currently in accounting, but in a different life, I worked in the research field between 2002 and 2008. And that was probably the main reason they felt that I should go to the PCRI conference. The other being that I think they were so attached to the weather in September with 4 degrees away, and nobody wanted to go to Los Angeles. We couldn't get a single person for it. That's why they sent me. So I'm going to talk to you a little bit about the treatments, the latest treatments that they talked about in the conference over there. So this was a 2.5-day conference, and it focused on all aspects of prostate cancer, from diagnosis to the current treatments, to current views as to where the treatments are going, what kind of survival rates we're getting, and even the more cutting-edge stuff which has not even been published. They even talked about some of the palliative therapies. So all in all, it was, I think, about 24 to 26 hours of lectures, a lot of information there. I'm going to focus on a small snippet of it, which is some of the latest treatments, and that's where we're going to go. So disclaimer over there, which goes to repeat what Brad said, that this is not medical advice, and if you really want medical advice, do it like everybody else does. Google it. Don't expect it from me. So I'm going to start with something which is may seem slightly tangential, but I think it's pretty relevant. So this is a slide from some time back, and you can see in the year 1998 to 2002, these were the 10 most frequent cancers in male. And you can see prostate is right over here in the middle. It's 7.2%. Okay, and I'm going to come back to this slide so I can get a response from you guys. But now we move on to 2014, and there it's number 1. So I'd like to get your thoughts as to why do you think that is? Okay. Quit smoking.
Diagnosis, detection.
Detection, diagnosis. Anyone else?
Aging population.
Aging population. Wow. I didn't think everybody would get all 3 right, but yes, you got all the 3 reasons. This is a smart crowd. So the 3 reasons for it, first is that I think somewhere around 1967 to 1970, the world collectively realized that smoking is bad, right? Before that, they had advertisements for it, that this cigarette is so good, it's toasted and stuff like that. But that's when collectively people realized that smoking is bad. And at that point, the incidence of smoking peaked in United States and Canada, and it's been going down since then. And so over time, and a typical person would develop lung cancer approximately 30 years after smoking. And so from that point on, every 10 years or so, we started seeing lower incidence of lung cancer. This kept dropping. This is a lot lower than if you went 10 years behind and 10 years further behind than that. So this kept dropping. Interestingly, smoking also causes a lot of other cancers, including lymphomas, bladder, liver, and stomach, and a lot of cancers that are not mentioned here. So all those rates have been dropping over time. So that's one primary reason that prostate has been going up. It's not like we suddenly started developing an extra prostate or something and started getting an extra cancer of that. So that's the main reason. The second reason mentioned is that we have an aging population. People are living longer, and prostate cancer occurs in the latter decades of life. So as a result, we are getting more of that. And the third is more diagnosis. So now this is a kind of a tricky one because you'd believe that if just because we're diagnosing it doesn't mean the incidence should increase. We should be able to, if somebody has prostate cancer, sooner or later we'd figure it out. That doesn't necessarily work for somebody getting prostate cancer very late in life. They might not even have typical symptoms, or they may not have very strong symptoms. And 10, 20 years back, we might even have ignored those symptoms, and that person might have died of other causes before we actually diagnosed prostate cancer. So we're being very vigilant trying to catch the disease, so that's one reason, decrease incidence of smoking, and that we are living longer. So here's the progress over time. This is my favorite slide because it shows how far we have come. Sometimes people forget about the progress we make, and the typical questions we get is, when will we cure cancer? Well, it's a long process, and we're making a lot of headway. And you can see, 1975 to 1977, we had 68% 5-year survival rate. And 2002 to 2012, which is the largest meta study done recently, and of course it was done in 2012, you have to wait until 2017 to make sure that those are the 5-year survival rates that you're getting. And we're up to 99%, and it's actually 99.4%. With little rounding error, that would have pushed up to 100%. So we're making a lot of progress, and by the time these studies come out, they're already kind of dated because in the last 6 years we made so much progress. So somebody getting diagnosed today obviously is getting access to a lot better treatments than these people who made it into a 99% survival rate. Okay. So before we go into the latest treatments, I'm going to just briefly touch over some of the traditional treatments, which it's fuzzy. Is it? Everybody back can see this?
No, people can't see it. It's way too small.
It's too small? All right, I'll read it out. Okay. So the treatments include traditional surgery, which is prostatectomy. There's some variants of that, which include minimal surgery and robotic-assisted surgery. Brachytherapy is another form of treatment where the radioactive seeds inserted into the prostate. And that was one of the things they discussed in the PCRI, that they were saying that in the United States, where there's a very big incentive for the doctors and the hospitals to go for more expensive procedures, there was a leaning towards traditional surgery, even in cases where brachytherapy would be just as effective. I don't know whether Canada has a similar bias. I mean, I've not done the study on it. But they felt that over there was a lot of unnecessary total prostatectomies when brachytherapy would have worked just as well with minimal side effects. There's cryosurgery and hormone therapy, which is the androgen deprivation therapy, and active surveillance along with all of that. So the PCRI, is this slide clear enough? Is this enough in focus? Just here. Okay. PCRI is the gathering of the top minds in the field, and I was really impressed at how good the speakers were. Sometimes you can have really, really smart people, but they may not be able to communicate effectively what they're trying to get at. And they're communicating to a very huge range of knowledge. The people with minimalistic knowledge who've come there to learn about treatments for themselves, and then there are doctors and PhDs over there. And to be able to cater to that whole crowd, it's quite a challenge, I think, for anybody presenting. And they did a fantastic job, especially Dr. Eugene Yu. I was so blown away with his presentations and his ability to respond. We actually had kind of almost I forget his name, but he was one of the other presenters. He was almost like a heckler because he was trying to, I think they know each other for a long time and they were just having fun with it, but he was trying to prompt a lot of things out of him. But it still went really well with him being able to respond to all of that. So it's great information for diagnosis, treatment, palliative therapy. There's a lot of stuff about the different classifications as to what treatment is best, and maybe in the future I might do something related to that. And you also get a chance to ask the top experts because there are about, I think, 3 or 4 different question and answer sessions at different times. So that will move on to the actual treatments they talked about. The first one they talked about was Abiraterone. I'm assuming that's how you pronounce it. I've heard it a few times, slightly differently in each case. It's a new drug that has been approved in February 2018 by FDA and also in Canada along the same time point. There was a large latitude study done, which was done in 10 cities in Canada as well, which recruited patients from here. And the way this drug works is it blocks this enzyme CYP17, which leads to less production of testosterone. Now, usually the patients it's used in, they're on androgen deprivation therapy already. So they're getting their androgens blocked by one of many drugs. There are, I think, about 16 or 20 different drugs that can be used for androgen deprivation. And what those do is they basically reduce the testosterone levels in the body by about 90%. So if your testosterone level prior to treatment was, let's say, 100, after treatment with androgen deprivation, you'd be down to about 10. What this drug does is it reduces it by a further 96%. So you will go from 10 to 0.4. So that's a very big drop-off. And why do we need this drop-off? Because 100 to 10 sounds like a pretty big deal, and that should be enough. But what happens in prostate cancer, like with many other cancers, is whenever you make things difficult for the prostate cancer cells or for any cancer cells, they adapt. So when you deprive a group of prostate cancer cells of testosterone, the ones that can survive on the lowest levels of testosterone start growing, and the rest of them die or they don't grow anymore. So then you have a population that's dominated by cells which can grow on very low levels of testosterone. So this reduces it down by a further 96%. And that obviously, when they saw that in the initial trials, that you're getting a 96% drop off, they figured, okay, this should help in reducing prostate cancer, further metastasis, and it should improve survival. And that's what they got with this. So it was approved for usage in metastatic high-risk castration-sensitive prostate cancer. They found the risk of death is reduced by 38% versus using androgen deprivation therapy. Additionally, progression-free survival, which means people don't progress beyond the stage at which they are diagnosed with, improved by 71%. And there's also no gynecomastia, which is a common side effect of some of the other drugs that are used in prostate cancer. The most common side effects, if I remember correctly, were hypertension, high blood pressure, and hypokalemia, which means you're going to be short of potassium. Those are the 2 major side effects, and hot flashes with this drug. Okay, so this might be a little hard to read, I guess, based on what you'll have told me before, so I'm going to read it out to you. So this is from the Prostate Cancer Canada website, and it shows which provinces this drug has been approved, because this has just recently been approved overall for Canada, and then the provinces themselves decide whether they have the funding or not for it. So it's approved in Alberta, British Columbia, New Brunswick, Nova Scotia, Ontario, Newfoundland, and Quebec and Saskatchewan. It's not yet approved in 5 other provinces or territories, but luckily it's already approved in Alberta, so it can be used over here. With that, we'll move on to the next drug we did talk about, was Docetaxel. This is a very complicated slide. I tried to find something that was more, something more, what the word for it is. But they cannot seem to be able to explain this in a less complicated manner. So I'll try to explain what this slide means. So The mainstay of treatment for prostate cancer has been the androgen deprivation therapy and prostatectomy. If you think about it on a broader scale, that's what it's been. We've not had a traditional chemotherapy drug. When you hear about chemotherapy in other cancers, those are those hard-hitting drugs which basically work on cells that are rapidly dividing. Any cell that's rapidly dividing, we have about 50 of them drugs which work in different cancers, and they interfere with rapidly dividing cells. So we've not had one which worked well in prostate cancer until now, and this is the first one. What this does is when a cell is about to divide, it has these microtubules which give the cell structural integrity. It keeps the cell perfect as it's dividing. So what it does is it interferes with those microtubules. It kind of wrecks them, so they're kind of twisted. And when they go into the cell division phase with the microtubules disturbed, the cell basically kills itself. Say it commits apoptosis or apoptosis. They still can't figure out what to pronounce that after 50 years. The cells basically kill themselves. So that's what this drug does. And it's a pretty powerful one, and it doesn't seem to have a very strong impact on other cells in the body. It seems to work really well on prostate cancer cells. It does have its usual chemotherapy side effects. Basically, 90% of them seem to be related to the gastrointestinal tract, with nausea and vomiting being at the forefront of it. So basically like the first trimester. And outside that, there's hair loss is one of the other side effects. So the results they got with this were they got significantly improved survival, and the overall survival time was 81 months versus 71 months with the standard of care. So the standard of care is it's not a placebo. Standard of care is the best available treatment that we have versus the best available treatment plus docetaxel. So that's how we determine how well it's working. They also found that this is not part of this 81 months versus 71 months. They also found that docetaxel works early on better rather than waiting for hormone therapy to fail. So these trials were kind of subdivided into different groups. And some cases, the patients came when the androgen deprivation therapy was not working anymore. The PSA was rising, the prostate cancer was becoming larger. So in those cases, docetaxel didn't work as well. It worked better when you put it on early on. They were kind of surprised that docetaxel works so well early on, but in some ways it makes sense, because what they figured out is using a 1-2 hit, they were basically destroying cells that later on would become resistant to the androgen deprivation therapy. So you take those out early when the mass is small, and you increase the chances of survival of the patient. This too is approved in Alberta, British Columbia, Nova Scotia, Ontario, Quebec, and Saskatchewan, and Yukon. I was kind of surprised when I started going through this. This was kind of an afterthought. Obviously, they didn't talk about this in the PCRI, but I thought I'd pull it up because I didn't even know whether these drugs were approved or not. And I was kind of surprised to see how each province basically is making a different decision. And the 3 drugs I'm going to talk about today, the lists are all different. So different drugs are approved in different provinces for treatment. So where you live might really impact what happens to your treatment. And nobody should go to the Northwest Territories, by the way. That has not approved any of these 3 drugs. Finally, we come to the third drug, which they talked about, which is Xofigo. This is radium-223, a radioactive substance. And radioactive substances have been long used in different cancers because they usually are very targeted treatments. They go to the specific site that you're trying to send them at. The most famous one that's been used is radioactive iodine for thyroid cancer. because iodine gets trapped only in the thyroid, and it basically kills off the thyroid cells. So it's one of the best treatments for taking out the remaining cancer cells if they exist anywhere in the body after thyroidectomy. So radium-223 is a recently approved drug which is used for bone metastasis. The key about this drug is that the approval is to use this drug for people who have bone metastasis but no visceral metastasis. By visceral means pretty much in any organ other than the bone's not an organ, but in anywhere else other than bone. So if there are any other metastases, you cannot use this drug because it'll create a lot of complications by going into that organ. So it can only be used when there's bone metastasis but no known visceral metastasis. So I'm sorry? No. So, Doctor, you believe that this may add approximately 2 years to progression-free survival with a few cures as well. The key part about using this drug is to use it as soon as possible when the patient becomes eligible to use it. That's the feedback I got from him. The reason is that it's very easy for the patient to become non-suitable for it. The moment they get a visceral metastasis, they're no longer suitable to use this drug. And what this drug does is it reserves some of the other drugs for later on. Because if you use those Docetaxel and Abiraterone early on, you may no longer be eligible for Xofigo once there is some signs of visceral metastasis. So you want to have as many drugs as possible which can be sequentially used, and hence he believed that using this one as soon as the patient is eligible to be put on it would be most beneficial.
So Saif, just a question.
Sure.
Was Dr. Yu really speaking about the current approved approach to using Xofigo, or was he talking about an approach that would be off-label? Because at least in the Canadian context, the advantage is understood to be about 3 months of progression-free survival, and I don't know what the overall survival is, but it certainly wasn't based on an early intervention of the drug. So I'm thinking his bias here is an early intervention that may not yet be on the label.
That's a good point. Let me think about that. I think he was using it in his treatments the way he described it.
Mm-hmm.
And he said that he did it simply because from the perspective of having Xofigo first, Abiraterone next, and Docetaxel after that, he felt if you waited a little bit to use Xofigo, you would not be able to use it. So he was using it early, and I'm not sure whether he is part of a lot of clinical trials. So it's kind of, might not be clear whether he's talking about the approved usage versus what is going on in his clinical trials.
I like the idea of early use, but I don't think that's the basis on which it's being reviewed in
Canada?
Canadian context.
Okay. Yeah, it might again be different in Canada versus US. So this is coming to a province near you. BC just approved it, but Alberta is still not on this list. So hopefully this gets reviewed by Alberta soon. This was the website was last updated in April 2018, but they review them all the time, and hopefully Xofigo should be available for usage in Alberta soon. Talk about another class of drugs, which is something which a lot of people know about, both men and women have used. It's the statins which are used for cholesterol, most famous of them being Lipitor. They found that statins that are used for cholesterol reduction might be a significant weapon against prostate cancer because they seem to impede the same pathway that prostate cancer used to transport testosterone into the cells. So they found some anecdotal evidence when, along with androgen deprivation therapy, or along with abiraterone, where you're reducing testosterone even further, they found you're getting a further compounding effect by using statins. And they weren't trying to use statins. It just happened that these people were already on cholesterol-reducing drugs like Lipitor. And then they segregated the data, put people who survived and put the ones who took statins and versus who were not taking statins. They found that, hey, you got a better survival in the statin group. So they actually went back, this data on this is back like almost 2 decades back, that statins do interfere with testosterone getting into cells. But nobody really bothered with it because that was not the primary purpose of the drug. But they're finding that it might work to improve overall survival. He did caution, though, that it's too early to start liberally prescribing Lipitor as an additional agent because the statins which impede the testosterone getting in also impede the testosterone blocking drugs from getting into the cell. So it's the same pathway. Overall, it does, at a superficial level, the study wasn't designed for that. Whatever we've seen, it seems to help. And it's possible that within, if they can find a certain statin that blocks only the testosterone and not the testosterone drug, blocking drug, then we might be able to use them as another class of drugs. And these, lower your cholesterol and reduce your prostate cancer metastasis risk at the same time. Now I'm going to move on to genetic testing. This is something which was very interesting for me because we've used a lot of treatments and therapies for prostate cancer that we thought would work, but they haven't worked really well. And this kind of gets to why that may be. So far, genetic testing has not gained far and wide acceptance, but it needs to for prostate cancer, according to the experts I spoke to. But they're finding that in a subset of prostate cancer patients, about 12%, genetic inherited mutations are responsible for the disease. So what that means is the person has a gene mutation. Everyone over here has heard of the BRCA gene, right? Yeah, so they believe that the gene mutations that are happening in certain prostate cancer patients is similar to that. They're highly predisposed to it. And these subsets have hypermutated prostate cancer cells. And it's in this group that you can get multiple years of life extension by using immunotherapy. So the logic behind it is that the regular prostate cancer cell looks so much like a regular prostate cell that the immune system doesn't treat it as a hostile. But in about 12% of the patients who have these genetic mutations, the prostate cancer cells look radically different. The immune system is able to recognize them as an offender, as a hostile, and would attack them otherwise. So in those cases, if you stimulate the immune system, you will get a very good response and it'll clear out the cancer. So what they're doing for this, this is really small. So Dr. Alicia Zhou is working at the University of Washington, what is known as a gentleman's study, and I don't know why they named it that because a lot of wives were not happy about getting their husbands enrolled in it. But they use this study to figure out which are those people who are developing prostate cancer because of genetic mutations and who are at a higher risk of developing high metastatic disease. And from what I heard, Dr. Yu mentioned this in passing, is that if you have a US address, you can actually go online and participate in this, and they'll send you the whole kit to get tested, and they'll do a whole genetic workup. Now, why would people want to do that? Key reason is they figured out that the 12% of the people who have that genetic mutation, they don't respond very well to conventional therapy. And they respond really well to immunotherapy. And they respond very well to PARP inhibitors, which is another form of treatment that they can get. So we need to basically distinguish the people that are eligible or would respond well to that kind of treatment. And the second impact of that is first is to get them the immunotherapies that they may need. And the second impact is they will be expanding the screening for relatives. The reason is the people who have these kind of mutations that are causing prostate cancer, the aggressive form at an early age, you're finding that these mutations run in families. So their siblings can get examined at an early age. You're also finding that these gene mutations go along with the BRCA mutations. So you're getting maybe their sister or their daughter getting screened at an early age for breast cancer. So this genetic screening has a lot of uses, and they're trying to expand this. Right now, it's part of a pilot trial, but if anybody has an address in the United States and they feel they can go online, they can fill out the information, and if they qualify based on their criteria, then and if you have a US address, you can get genetic testing done. At present, we have only one broad form of immunotherapy, which is used in everyone. Again, it would probably work better in that subset, but right now we've been using it in everyone. That's called Provenge. It's a drug from Pfizer. What it does is it takes the person's immune cells out, and it activates them against a prostate cancer antigen. So it takes your own blood out, it puts them into an environment where it's stimulated with a prostate cancer antigen. It's given GM-CSF, which is a hormone which basically makes the T cells active. And then those T cells are put back, and it tends to work. It's not a very powerful radical therapy, but it's also one that doesn't have many side effects because you're using the patient's own T cells and you're stimulating against a very specific antigen. So it's kind of a very calm therapy in that sense, because some of the immunotherapies can be pretty radical and have a lot of side effects. This one doesn't have that. So I still don't know how to pronounce that one also. Ipilimumab, I guess that's the one. The first study, checkpoint inhibitor. So this is the first drug that has been used to try to stimulate an immune response in all prostate cancer patients. So this drug is blocking the PD-1 pathway, and I'll get to what that pathway is a little later on. And they found that this drug doesn't work really well in most patients. Most patients showed absolutely no response, but they were getting sporadic cases of complete remission. So this actually is the reason that they went on to the genetic testing, because they're figuring, why are we getting complete remission in some people and not the others? And then they're figuring out the 12% of the people who have hyper-mutated prostate cancer cells, whose prostate cancer cells look radically different than regular prostate cells. Those are the people you're getting this response in. So that was actually the basis of going back and starting the genetic testing to try to figure out a subset of people in whom these drugs can have a very strong impact. And there are multiple grants out there right now trying to, dice this out so that we can use this drug, especially in the right population. Oh, I just ran through my next slide. Okay, so when I heard the PD-1, I was wondering where had I heard this term before. So that's me over there, Saif Lalani. So we worked on the same stuff in Vanderbilt University, and we worked on basically a mouse model of skin cancer. And what we did was, mice don't look very nice when they get skin cancer, unfortunately. And what we did in them is we used a blockade of PD-1 and PD-L1. So these are the checkpoint inhibitors in an immune response. So these are the cells which tell an immune cell whether or not they should attack a cell. So as the immune cell goes around in the body, it finds a lot of friendly cells, and the way it knows not to attack them is by interaction of PD-1 and PD-L1. These two molecules bind to each other, and that tells them that they don't need to attack the cell. However, cancer cells also possess this, and that's the way cancer cells escape the immune system by telling the immune system it's fine not to attack it. So blocking this works really well. So we found that out, and when we did this stuff in mice, it worked really well. And this has been expanded actually into melanoma in stage 4 in humans. And in patients who have a high level of PD on their cells, you're getting almost a 70% cure rate 5 years out, which is truly stunning, I think so, that you can cure skin cancer in stage 4 by using this drug. And so the key of the last few slides is we're trying to get this kind of cure rates in prostate cancer. And the reason we have not succeeded so far is because we've been trying it too broadly. We're taking all the people with prostate cancer and we're giving the drug to them. And that's not necessarily the best way to do it. We need to find out the patients who are best suitable for this kind of immunotherapy. It works really well in melanoma in everyone is because melanoma is a radically different cell. So I'm pretty sure most of you all haven't looked under a microscope in a long time, but if you saw a melanoma cell under the microscope and you looked at a skin cell, you'd know it's different. They look radically different under the microscope. If you looked at prostate cancer cell and you looked at regular prostate cell, they look pretty similar. And that's the same way the immune system sees them. With melanoma, it already recognizes the cell as extremely hostile, but because of this molecule, PD-1, it's not able to attack it. It's not getting the go-ahead. So once you take away that blocking mechanism, it just completely ransacks the melanoma. But we've not been able to do that in prostate. And the key in the next few years is to find out how to get there. And the first step is the genetic screening to figure out the people who are going to benefit the most with this therapy. And I think within the next 3 to 4 years, this drug will probably be used in a small subset of prostate cancer, and we'll get pretty good results in them. And these are the same people who are not making it to the 5 and 10 years. So it's really a very critical distinction that we are going to get. We are actually targeting the people who are not making it to the 5-year survival and the 10-year survival rates. And I think one slide's missing, Brad. You took out one slide. Okay, must be somewhere else. I had the PD-1, PD-L1 interaction. I thought I did. Maybe I didn't. Okay, so there was a lot of talk about supplements, and people like to take all kinds of vitamins and minerals to help out with the disease. What I got from the seminar was that vitamin D was the only supplement with some compelling evidence to help out in prostate cancer, and the minimum we should be getting 1,000 international units of vitamin D. People are taking very radical amounts, 10,000 and 50,000, but there's no evidence that that works, and it may actually cause you harm rather than good. And as for the other supplements, there's always something on the web that claims to create radical stuff. So if you believe the scientific literature and the best minds who are waiting to find the cure and be the one to get the Nobel Prize, there's nothing else out there that seems to work like that. Summary is that Abiraterone, Docetaxel, and Xofigo show ability to add significant amount of years to patients' lives, and I think that's going to be the next step to getting a 99% 10-year survival rate versus the 5-year survival rate that we have right now. Each additional couple of years you add, you also give the patient a chance, you additional to adding the life itself, you're also making the potential for new therapies to be discovered down the line that could help that patient. Genetic testing may be able to pinpoint which patients will benefit the most from immunotherapies and which patients are at most risk for developing the advanced, aggressive metastatic forms of cancer. So this is something that really hopefully will be expanded to include everyone, but it's also a point where people might be able to get it done by themselves. If you look at the cost curve of getting a full genetic examination, it's falling very rapidly, and each year it's about half as much as it was the previous year. And now it's getting to a point where people might be able to get it done themselves. And certainly in a few years, I think everyone will be able to afford it, even if the government doesn't pay for it. And that's going to be critical towards figuring out which patients are the biggest risk and who will benefit from some of these newer treatments. Approval of treatment varies by province, but you should keep checking to see if a certain drug has been added to the list. These drugs are very expensive. I think Xofigo is $90,000 for the whole treatment. And Docetaxel and Abiraterone are in the same ballpark for the entire course of treatment. So they're all under patent protection. And we just gave away 2 additional years of patent protection in our new deal across the border with Trump. So it's now gone from 8 years to 10 years. So that's something we're going to be paying for. So that's it, what I have. And if you guys have any question, I will try to answer them.
Let's say I have a question.
Sure.
You said, we had a meeting last week, and you were saying that the general atmosphere was quite a positive approach to the progress that's being made, that's happening, right?
Yeah.
So what are people saying, and who is saying that? And can you just share more? Because it seems positive.
Well, there are 2 ways to look at it. I mean, when someone is personally impacted by it, we don't look at statistics, right? We just look at that person. But at a statistical level, prostate cancer, the 5-year survival at 99% itself.
Use the microphone, please.
Oh, sorry. Yeah, I'm too far from that. So if you look at the prostate cancer survival at 99% itself, that itself is one of the highest among the cancers that we know of today, right? And part of that is because we're diagnosing it pretty early. I think the key aspect which they're very excited about is they've identified the ones with the most aggressive forms of prostatic cancer, and they feel a bulk of them are people who have genetic mutations, and they would respond to drugs that are working really well in melanoma. So I think that is the thought process, that we know the ones that are not making it, and we know what's wrong with them. We just need to, and we know what might possibly work. And that's the one drug which I told you, that's not the only one. There are 3 or 4 different ones. That's PD-1, PD-L1, CTLA-4 antibodies. So there's a lot of those drugs out there which can be used together individually or in combination.
Saif?
Yeah.
Where was active surveillance positioned in the enthusiasm that was being shown for the later treatments as opposed to the early detection?
So that comes down to the classifications, and the azure and the blue and the sky and the navy, or that scale. You must be familiar with that scale, right? Yeah. So there are a lot of different subsets that they felt, and it'd be kind of hard to show you without the chart over there. But there are a lot of subsets that they felt based on a scoring system. They were strictly based on a scoring system based on the grade of the prostate cancer cells they found, and the PSA levels, and the family history. So when you add up all of them, if the risk is low, they were very enthusiastic about active surveillance. They're saying most patients are too scared to go on active surveillance, and they just want the prostate cancer out. But very long-term treatment, long-term studies over 20 years are showing that the survival is about the same when the grade is very low and the risk is very low. And what some of the people over there are trying to push is like, okay, if you still want to do something actively over there, brachytherapy might be an in-between step, which is less aggressive than a prostatectomy and seems to work really well.
So just a further final one for me. Was there an individual talk, I think Dr. Kwan from
Not that great with names, but I think I was on.
Amazon.
Mark?
No, Dr. Kwan.
No, Mark.
Was he speaking about um, early detection with imaging tools, and then either surgery or focal therapy against what he discovered? A few years ago, he made a presentation,
Mm-hmm.
and the way that it was described was you picked the ball out of this cave. In other words, it was such a profound presentation that he made. And I think he was speaking again this time. So I guess maybe the ball didn't get kicked out of the stadium quite as far. I don't know.
I don't recall whether it was him or not, but if you're talking about the latest imaging studies, they had a separate session just on that.
Yes.
Yeah,
Okay.
yeah. And just improving the diagnosis times. And
Yeah.
yeah. There seems to be a little bit more controversy on the PSA stuff right now. And so I think the imaging studies were kind of an adjunct to that. They still, like, the people are still divided on the PSA studies, so we got some different responses on that.
That's good.
Yes.
Yeah, they are in the process of possibly changing my chemo treatments. And I've gone through the, excuse me, Docetaxel. And their oncologists are talking about switching to the cabazitaxel. What is it? Cabazitaxel. And I'm like, it didn't show up in your slides, and I'm just wondering, is there any correlation, or are they basically going to be doing the same thing?
I'm not aware of that drug, unfortunately. Yeah, it didn't come up actually in the sessions. So is this supposed to be a more latest treatment, or is it some of the older drugs that have been used?
It's actually a drug that was released about 2010.
Can you repeat the name? I didn't quite catch.
Docetaxel.
Okay.
And it's the first drug that shows a survival advantage for somebody that has already been heavily treated with Docetaxel.
Okay.
So it's a second line chemotherapy,
Okay.
is the other way that it would be described.
Yeah, they didn't talk about that one. Or that.
Right.
Yeah, it sounds like the presentation covered docetaxel and early introduction,
Yeah.
I think is how I interpreted the,
Yes, early
The
intervention
study
with the androgen deprivation therapy.
Good.
Yes, yeah.
no other questions, good. Saif, well done.
Thank you.